Well, I'm Lisa Pappas-Taffer. I'm a dermatologist. I work at the University of Pennsylvania. I'm part of our autoimmune group in dermatology, and I focus on sclerotic conditions, including morphea and systemic sclerosis. So today we're going to talk about morphea, historically called localized scleroderma. What are we going to talk about? Nomenclature. So what are all of these different terms? Morphea, localized scleroderma, systemic sclerosis. It's confusing. We're going to go over it a little bit. It's confusing to me, at least. Morphea versus systemic sclerosis. How do they differ, and how do we differentiate? What are the clinical features and subtype of morphea? And we're going to talk a lot about prognosis and also a little bit about treatment as well. So scleroderma, what does this term mean? So literally it means hardening of the skin, and derma is really meaning disorders of the skin, so hardening of the skin. We know that scleroderma in the medical community means much more than hardening of the skin. It's actually a systemic disease. It's affecting sclerosis of not only the skin, but also of organs. So because of that, a lot of times we refer to scleroderma as systemic sclerosis. Can you refer to them as both? Absolutely. And there's some subtypes also, diffuse and limited. And then there's a localized scleroderma. In opposition to the scleroderma systemic sclerosis change, we really have changed completely in dermatology to utilizing the term morphea instead of localized scleroderma. Why? Because morphea does not turn into systemic sclerosis. Super important to know. And we'll go over that more too. So I see a lot of patients, both referred by providers, but then also just coming in on their own saying, okay, so I was told I have morphea, but my biopsy says scleroderma. Can you help me differentiate? Absolutely, I can. But the first thing to know is that you cannot differentiate systemic sclerosis from morphea by biopsy. If you take a biopsy of the skin of somebody who has one round, hardened area of the skin, morphea, and then you take a biopsy from somebody with diffuse cutaneous systemic sclerosis, kind of diffuse hardening of the skin, including the fingers and such, you put those biopsies next to each other, they look exactly the same. What's different is what the provider's asking for. If they say, rule out systemic sclerosis, the dermatopathologist is going to come back with a report that says, yeah, that's consistent with systemic sclerosis. If the dermatopathologist says, rule out morphea, the dermatopathologist is going to say, yeah, that's consistent with morphea. It looks exactly the same. Do I biopsy patients? Absolutely, I do. But I'm not differentiating between systemic sclerosis and morphea. So what are the differences? Well, there are differences in clinical findings. There are differences in presence or absence of internal organs that are involved. Completely different prognosis. And then the question is there a difference in pathogenesis? So at the end, you're having this sclerotic or hardened area of the skin, but what are the differences? And the thought is that they might have a different pathway. So morphea has a tendency to be more inflammatory than systemic sclerosis, and so that's an active area of research. So here's two patients of mine. On the left, a patient with systemic sclerosis, diffuse cutaneous systemic sclerosis, in fact. On the right is a patient with morphea, generalized morphea. How can I differentiate them clinically? Because I absolutely can. So on the left, you're going to see this patient has these bound down, kind of hyperpigmented or brownish plaques underneath of the breast. On the right, the patient looks somewhat similar with these brown, slightly depressed, hyperpigmented patches and plaques. Difference is their hands. If you look at the patient on the left's hands, they're edematous, sometimes hardened or tapered at the ends. If I look closer with something called a dermatoscope, that's going to be a magnifying glass with a light. It has some bipolarization, so it's a little different than just a magnifying glass. I'm going to see abnormal capillaries or abnormal proximal nail folds. Proximal nail fold is going to be at the base of your finger where the skin is. If I'm going to look at it, I'm going to see many different changes, but really abnormal vessels. The other thing is I'm going to ask this patient, do you have Raynaud? When you go out in the cold, do you have a change in color? Does it turn white, then purple, then red? A systemic sclerosis patient, by and large, is going to say, absolutely. So what about my morphea patient? My Morphea patient, if you can see her hand is totally normal. She has no edema or swelling of the hands. She has no bound down fingers. She has no changes of her capillaries when I look under magnification. And when I ask her, 99% of the patients are going to say, I don't have any changes when I go out in the cold or when I go to the grocery store or such. So can I absolutely tell this patient, you have Morphea, you don't have systemic sclerosis? I can. I can also tell her that no further workup is needed. So what am I looking at under the magnification? So if I look at the upper left, I see this kind of fuzzy erythema or redness. The top right, I'm going to see these vertically oriented, dilated capillaries. Do I see this in somebody? Do I see this in, let's say, my finger? No, I would just see kind of plain white. If you look on the bottom left, you're going to see these dilated capillary loops. This is systemic sclerosis. This is what I'm looking for in my systemic sclerosis patients. And what happens over time, if you look to the right bottom, you're going to see dropout. And when I see this, I'm seeing kind of, it often will correlate with ulcerations of the fingers and further morbidity or problems with the fingers. Am I going to see this in Morphea? I am not. Interestingly, one of the reasons I'm always not only looking at my systemic sclerosis patients' fingers, but monitoring over time, because there are studies showing that this actually reflects what's going on in the lungs too. So it's a good way that we can kind of monitor without being able to see the lungs themselves. So again, a Morphea patient isn't going to have that. So if a patient does not have Raynaud's syndrome, they do not have hand edema or sclerodactyly, and they don't have proximal neofold capillary changes, I don't need to work this patient up further for systemic sclerosis. I'm not doing further workup. So what about this internal organ sclerosis? Do they differ between Morphea and systemic sclerosis? Absolutely. With systemic sclerosis, not everybody has internal involvement, but some patients do. What do they have? Sclerosis of the, having an effect of the heart, gastrointestinal tract, kidneys, lungs, distal vasculature. Do Morphea patients have this, or could a Morphea patient develop these? No. So what about prognosis? So yes, there's a big difference. The big difference is Morphea does not progress to systemic sclerosis. So that is the main reason that in dermatology, we've embraced the term Morphea over localized scleroderma. It is not progressing to systemic sclerosis. So how do I approach a patient with Morphea in the clinic? So I ask a series of questions. So when did it start? Are your lesions itchy? A lot of Morphea is not itchy. And when it is, I can tell patients, you know, you're probably going to progress quickly. You're probably going to develop spots elsewhere. And this is a reason potentially to treat more aggressively. So it's a nice clinical clue for me. Do you have a family history of Morphea? Most patients do not have a family history of Morphea. Only 1% of patients with Morphea have a family member with Morphea. But what they do have is they often have family members with autoimmune conditions, either themselves or their family. So I'm often asking that. So travel to Europe. The reason I ask this is to introduce a question that most patients have for me. Does Lyme disease cause sclerosis of the skin, or Morphea specifically? And the answer is that there are no known cases of Lyme-induced Morphea in the United States. There are cases of a specific Borrelia species causing a sclerotic condition in Europe. It's different though. So by asking this, I'm introducing patients' questions or entertaining them, which I want to do. I always ask, is there association with preceding trauma, surgery, or radiation? Morphea has a tendency to come up in areas of trauma. So there's radiation-induced Morphea, for example. It'll come up in areas of radiation, but it'll also come up in areas that are distant as well. Why this happens, we're not sure. Also an area of active research. And then, of course, I'm always asking history of Raynaud. As I said, most patients do not have Raynaud's syndrome. Can they, though? Absolutely. There's something called primary Raynaud, and there's something called secondary Raynaud. Primary Raynaud is where people have a tendency to develop this early on, more so in their teens to early adulthood. In secondary Raynaud, which occurs commonly in connective tissue diseases, it often occurs later. And often it's an inciting event, specifically in systemic sclerosis. Most patients develop Raynaud syndrome first. So what am I looking for on exam? Well, I'm looking, is there activity or is there not activity? We'll go over a little bit what activity looks like. But that's important because it differentiates how we treat. What about a deep component? If there's a deep component, meaning there's inflammation deeper into the skin or into the fat, then we treat it very differently, more so with a systemic medication, oral medication or such, because a topical isn't going to reach. I'm always looking at location, finger involvement, proximal neofold capillary changes, because as we talked about, that can help differentiate from systemic sclerosis. And what do I do over time? Well, I monitor patients, whether they choose treatment or not. So I take a lot of pictures so that I can see over time, not only so I can see, but so patients can see too. And we do some measurements too, depending on whether it's a reasonable thing. If it's a lot of lesions, we don't do all measurements. If it's one lesion, we do. So how do these present? What's an early lesion versus what's what we call burned out lesion? So burned out meaning no activity, meaning something that we wouldn't be treating. So an early lesion often is red to purple patches or plaques. They often look bruise-like. Patients will come in saying, you know, I've had this bruise for a really long time. It won't go away. What is it? And then over time, what has a tendency to happen is it will become thicker or white in the center. And then we often will refer to this violaceous ring in dermatology. And what that is that kind of purplish red surrounding. That's telling me that there's inflammation or active areas that we can target with anti-inflammation or treatment. So what happens when it resolves or when it's inactive? So this is what I call burned out. So a lot of times I'll describe it to patients as you will have a skid mark on the road after the car is gone, meaning there's going to be evidence that something was there, but the main process isn't there anymore. And so you'll see the sclerotic, somewhat hairless, sweatless patch of skin. So Morphea subtypes. So there are multiple subtypes of Morphea, really based on how they look clinically. So the first type is circumscribed or plaque type. So that's going to be 1 or 2 lesions on the skin, usually round, but can be, you know, multi-shaped, and it can be superficial or deep. What do we mean by that? Deep would be the inflammation is deeper, so can affect either the fat or sometimes either the muscle and the bone. So what is generalized? Generalized just means you have more spots on your skin, so usually greater than 4. It can be superficial. It can be deep, meaning a deeper inflammation, and there's a subtype of that called pansclerotic. That probably has the worst prognosis, and we'll go over that a little bit. That means there's going to be sclerosis of your entire skin. In fact, sometimes it can look like systemic sclerosis, but there's a big difference. It's going to spare the fingers. It's also going to have all of the other features that we talked about, not having Raynaud syndrome, not having the proximal neofold capillary changes. So what's linear? Linear morphea is where there is almost a line of indentation that can affect different areas of the body. That is a type of almost deep morphea because it's affecting the fat, sometimes the muscle and the bone. It can happen on the trunk or the limb where somebody has a long line. It can happen on the scalp or on the face. We call that in coup de Sabre. So what is in coup de Sabre? So that means strike of a saber because it's an indentation often on the face or on the scalp. And there's also progressive hemiatrophy, which is thought to potentially be a subtype or very associated with in coup de Sabre. And for that, there's really, classically no overlying change to the skin, but affects the deeper tissues only, most commonly on the face. There are some others that people have classified as guttate or bullous, but those are a little bit controversial. I included them just for completeness. So let's talk about your classic, kind of your most common circumscribed or plaque type, which is superficial. This is going to be 1 or 2 plaques on the skin that can look very similar to some of the pictures that we showed. It's often in areas of pressure. What's the most common location for women? Is actually under the breast, mainly due to friction. And here, although it's somewhat hard to see, you can see that slightly sclerotic, yellowish white plaque with that surrounding area of erythema. So now you know, hey, there's inflammation there. We should probably treat it. So here's deep morphea. So here it is localized. What do we see on this young woman's leg? We see these indentations. We're not seeing a lot of inflammation. Meaning we're not seeing a lot of redness. Does that mean there isn't any inflammation? No, because it's deeper. These are harder to track, so that's again why I'm doing pictures and sometimes measurements of it also. We do want to treat it aggressively. Sometimes it's called, in fact, often it's called morphea profunda, meaning affecting the fat, because it's affecting the dermis, the second layer of the skin, and the fat, that's why we're getting those depressions. Most commonly when it's localized, it's on the lower legs, but more commonly, deep morphea is generalized in nature. So generalized. It can be superficial, meaning it can look very much similar with that circumscribed patch or plaque. You just have more of it. Then there's, it's typically more than 4. These patients, when it's generalized and superficial, are more likely to have a positive ANA, so autoimmune antibodies, and more likely to have systemic symptoms. You're going to say, hey, Dr. Pappas, you told me there's no internal involvement. What are you saying here? So these patients often can have fatigue. They can have more joint achiness, but it's not actually affecting these locations, meaning there's no active inflammation in these areas. So generalized morphea, as we said, this is more of a superficial variant, multiple lesions on the skin. It can look very different depending on skin type. So it's very important that patients be followed by somebody who sees a lot of morphea so that you can tell when there's erythema, when there's activity, so that it can be treated appropriately. So generalized deep morphea. So we talked that a lot of times deep morphea is more generalized rather than localized. And here you see 2 different variants or 2 different flavors of how it can look. On the left, you're seeing these hyperpigmented patches kind of coalescing. It's hard to photograph because it's something that you can feel more than you can see. This is going to be indented, and that's kind of what I feel on exam. And sometimes there's a combination of kind of superficial and deep. However, you also can have the appearance on the right, where it's diffuse sheets of thickened skin that's affecting not only the superficial skin, but also the muscle and sometimes even the bone. This is what we call the cellulite-like appearance. It's a dimpling or kind of irregularities on the skin. This is rock hard. And sometimes these patients absolutely in fact, most of the time they're referred, is this systemic sclerosis, is this not? There's also a condition called eosinophilic fasciitis, which is thought to be kind of on a spectrum with morphea. And this specific patient doesn't meet criteria for our pansclerotic morphea, but does meet the criteria for a deep morphea. So what is this pansclerotic that I made mention of? Pansclerotic is the most debilitating, super rare. This is something that's affecting globally, down fat, bone, causes muscle atrophy, joint contractions, non-healing ulcers. These patients have increased risk for open sores and also squamous cell carcinomas. What are squamous cell carcinomas? They're a skin cancer, kind of the second most common type of skin cancer caused by the sun, but in this setting, it's due to kind of chronic wounds and such. And actually, about 6% of patients will develop squamous cell carcinomas per year. So it's important that they're followed by dermatology, not only for treatment of this condition, but also for skin checks for skin cancers. Are most patients with morphea at increased risk for skin cancers? No. Do some of the medications that we treat morphea with increase the risk for skin cancers, such as systemic immunosuppressants? Absolutely. Most patients on systemic immunosuppressants should be seen by dermatology usually once a year. So here's additional pictures of pansclerotic morphea. So this is sheets of sclerosis. Looks very similar, these pictures at least, to systemic sclerosis. How are we going to differentiate? If you look at the hands, there's a sparing of the fingers. Totally different than systemic sclerosis. And again, no proximal nail fold changes of the capillaries, no Raynaud syndrome and such. So let's move on to linear. So linear morphea is the most common subtype in children. In fact, in the past, it was thought that this was a disease of children only and that it wouldn't recur. We now know that's incorrect. We do know that linear morphea is likely to have underlying involvement, meaning affecting the fat, affecting sometimes the muscle and the bone. So there's two types, or we categorize two types: trunk and limb, meaning kind of a long, almost trough-like effect on either the trunk or arms or legs, and head type. So we talked a little bit about in Coup on the scalp or the head, and progressive hemifacial atrophy. So for trunk and limb type, because it can affect underlying conditions, especially if it's overlying a joint, it can cause muscle atrophy. It also can cause limb length discrepancies. What does that mean? In a child who's actively growing, morphea, linear morphea can prevent limb growth. So there can be a difference in the length of the limbs. It also can affect the circumference, or how wide the legs are one to another. And if it's overlying a joint, it absolutely can cause contractures or prevention of that joint from moving well. The important thing, and the reason for patients to seek treatment early or be referred early, is because early treatment can absolutely reverse or prevent damage. This is a patient who came in within a month of this starting. What you see is a plaque of hardened skin on her ankle. It then progressed relatively rapidly to cause this serpiginous line of indentation and lightness. She presented quite early, kind of within that month. And at that time, we started pretty aggressive therapy. What did we start? We started IV methylprednisolone. We did pulse treatment. We did monthly for 3 months, and we started mycophenolate mofetil. Despite starting, she actually progressed within a month. You can see that she developed new lesions, and she developed even further troughing of that line. Well, 2 months later, that troughing reversed. We still see the hypopigmentation, but she has less involvement, and it's more superficial. So within 6 months, totally back to normal. So early intervention is key. So what about in Coup? So we talked about how this can affect the forehead and or the scalp. It absolutely can occur in adulthood. Does it occur commonly in kids, or more commonly, I should say, because it is not a common condition? Absolutely. But for example, this patient on the right, she's in her 60s when this started. This patient on the left, she was in her 30s when this started. Can reactivation occur in adulthood? So a patient develops as a child. In the past, we used to tell people, no, once it's gone, it's gone. Not true. It actually recurs in about 1/4 to 1/3 of patients. Good news is about 2/3 to 3/4 of patients don't recur, but we absolutely want to tell them, what a good prognosis, or what their prognosis would be. Another thing that's important is it can affect underlying ocular and central nervous system. So especially this patient on the left, you can see it actually involved her scalp first. She was biopsied by an outside provider. Then she was lost to follow-up. She presented to me with this line on her forehead, and it involved her eyelid too. So if you flipped her eyelid, you would actually see this hard sclerotic plaque. So this is a patient that's super important to have screened for eye involvement. This is a patient who actually came to me who had onset in childhood. She had the central forehead involved. And she was born in another country, lived in another country, came to me once she had access to insurance and healthcare. So what she said is that the spot in her scalp hadn't changed, but about 5 years ago, she noticed a spot under her right eye and down her nose. And then when I evaluated, I said, you actually have a spot above your left eyebrow and on your right forehead too. And she said, people at work have noticed this. So she did not actually have reactivation of her initial lesion. She had new lesions. So it's important, absolutely, to tell people not only could there be a reactivation, but more so you might get new lesions as well. So what is progressive hemifacial atrophy? So this is predominantly in children. This is atrophy of the fat, muscle, or bone, but classically with minimal overlying skin change. Some people, including myself, find this to be a spectrum of Coup. There's one study looking at kids, and actually they found 28% of kids had evidence of both diseases, meaning the atrophy of the face, but also in Coup in a different location. And 71% of patients, when reviewed by a dermatologist, were found to really have some overlying skin sclerosis, meaning some superficial involvement as well. Why is it important to actually screen patients for this? Because you can prevent asymmetry and facial cosmetic disruption. So linear Morphea subtypes often coexist. You know this patient from previous pictures. When she presented with a new spot on her forehead, she also had a lesion on her left hip, which is why I always do a full body skin exam on every patient. You never know what you're gonna find. And she actually said that this lesion that's kind of overlying her hip actually came out after trauma to that area. So again, always good to do a full skin exam and always good to ask additional questions. Here's another patient that has two conditions. She has in Coup, but also the progressive hemifacial atrophy. This developed in childhood for her, involving the scalp. But what you can see is, look at her face here. You can see on the right side that's very subtle, but she has kind of atrophy of her right nose and also of her cheek and forehead. You can see on the left that there also is some atrophy on the right side. How can we really determine when this started and try and determine if it's active? We look at school pictures. Everybody has their yearly school pictures, so we go through those and try to suss out when this actually started. Hopefully we can find it early. So let's talk a little bit about extracutaneous associations with Morphea, complications and screening. So again, I'm telling you, hey, there's no kidney, GI, lung, or heart involvement, but there are some extracutaneous or outside the skin associations that we should review, specifically musculoskeletal, neurologic, and ocular. Most of these are associated with linear morphea, or a morphea that's affecting deeper, or inflammation that's affecting deeper tissues. So muscle or bone involvement. So this actually occurs in 20 to 50% of linear morphea patients. When it's affecting the lower extremity, it can be associated with spina bifida, faulty limb development, or limb length discrepancies. If a patient comes to me and they have greater than 2 centimeters of a difference, I'm sending them to orthopedics. It can cause cosmetic disfigurement if affecting the scalp or the face, and it also can cause cramping. I use cramping as a clue of inflammation. When patients are cramping, typically we're going to escalate care. How can we screen for this? We can do x-rays, or we can do an MRI of the affected lesions, head or extremity. I typically do an MRI, and I'll do a baseline MRI. If there is additional cramping or such, down the road, sometimes I'll do a follow-up. What about neurologic complications? So this is more common within Coup. So about 20 to 40% of Morphea patients can have neurologic symptoms. So what are these? Most commonly seizures, migraines, neuropathy, so kind of either tingling or pain. You can have behavioral changes, central nervous system vasculitis or vascular malformations. So one positive aspect is that the skin typically presents before the neurologic. On average, studies say it occurs 6 months to 3 years after skin presents itself. So what do? I'm always checking a baseline MRI. Why? Because there's a poor correlation with the MRI and symptoms. So it's been shown that 50% of patients with neurologic symptoms have an abnormal MRI. So that means 50% of patients that are having neurologic symptoms will not have any findings on MRI. I need to know what the baseline MRI is to know if there's a change. What about ocular complications? What about eye complications? This occurs in 2 to 3% of patients. It usually manifests as uveitis or inflammation of the eye. Typically, there's no change in vision. So what do? In an adult, I'm going to do a baseline exam, ophtho exam, and then yearly. If a patient becomes symptomatic, then we'll do it more frequently. So what about blood work? So I check a lot of blood work on patients, but it's because I'm treating them with systemic medication, not because I'm doing anything to either diagnose the condition or give prognostic information. So a lot of patients with Morphea will have positive autoantibodies. So 40% of Morphea patients have a positive ANA. So does it mean anything? No, I often do not check it. So a lot of patients ask, well, what should I expect? What do I expect this condition to do over time? So the good news, it's a normal lifespan. This is not going to affect longevity of life. If you leave one plaque without treating it, which is an option, what will happen? Within 5 years, statistically, it'll go away on its own. That's great news. The chance of somebody developing a new lesion, though, is pretty high. So do I talk to patients that potentially we don't have to treat? Yes. Do I push patients who have deep involvement or have, in Coup to Sabre or such? I absolutely do. And we go over the risks and the benefits. So we also go over recurrence rates. So about, a fourth to a third of patients will have recurrence. What do I expect to see on the skin? Just what we talked about, that skin mark on the road. Patients will have pigmentary changes. It can either be brown or lighter. It will typically soften over time. But if it has deeper involvement, there can be contracture or limb length discrepancy. So it can affect the bone and the muscle and such, and that's what we're treating to prevent. How can we lower the risk of reactivation? We can treat greater than 2 years with immunosuppressants. There's one study actually looking at methotrexate specifically at the length of time. It was in children, and it showed that if treated less than 2 years, higher risk of reactivation. If treated greater than 2 years, lower risk of reactivation. How do we choose how we're going to treat this? So the choice of therapy is based on how much activity there is, the depth of the disease. Is this deep morphea? Is this linear morphea or such? Location of disease, is this overlying the scalp or the face? Body surface area, is this generalized or not? And disease course, is it progressing very rapidly or not? So there has been some consensus on indications for systemic treatment. Fat or deeper involvement, rapid progression, as we talked about, involvement of functionally or cosmetically sensitive areas in a large body surface area. I can tell you that it's a very patient-specific choice. My job is to tell people risks and benefits, what the treatment options are, how likely they are to work, and really allow me to help a patient decide which treatment would work for them. So are there evidence-based treatments? Absolutely. There's topical therapy, including topical steroids, tacrolimus, which is a calcineurin inhibitor. There's systemic therapies, such as phototherapy. There's narrowband UVB, and there's UVA1. What's the difference? So narrowband UVB is much easier to come by. It's in academic institutions. It's also in private practice. UVA1 is much harder to come by. It's only at certain academic institutions. For example, there's not narrowband UVB in New York City. There's not UVA1 in New York City. There's not UVA1 in Philadelphia. So it is harder for patients to access. Does it work because it penetrates deeper than narrowband UVB? It does. But a lot of times logistically it doesn't work for patients. What are some other systemic therapies? Are methotrexate, mycophenolate mofetil, and possibly prednisone short-term or IV methylprednisolone, again short-term. What is the difference? The difference is whether somebody wants to treat the lesions that exist versus whether they want to treat the lesions that exist but prevent new lesions from coming up. That's where I talk about patient-centered therapy. I need to find what a patient's goal is, and then I do my best to make it happen. So there is a proposed evidence-based treatment algorithm, but again, it doesn't work for all patients because sometimes phototherapy doesn't work for a patient's lifestyle. They can't get out from work. So again, it's very patient-based, and my job is to tell patients how well these therapies work. What do I offer? I offer active monitoring. There's some patients with generalized superficial morphea that say, let me tell you something, I don't want to be treated, but I want to know if it's getting worse. So what do? We do pictures, and we monitor over time. I usually see people on about 3-month intervals. Phototherapy, which we talked about, that's considered as almost a systemic medication. It doesn't affect anything internal, but you're treating all the skin at the same time, preventing new lesions from coming out. Plaquenil I talk about, Plaquenil is hydroxychloroquine, and for that, there's not great evidence that it works. However, anecdotally, some patients will come to me, they'll stop it, and they'll seem to flare. So I do discuss it and talk about it. But what are the treatments? If somebody says, hey, I really want to prevent new lesions and treat what I have, we're going to talk about two main treatments. Methotrexate, which has the most data in the literature, and mycophenolate mofetil. We actually just completed a multi-center retrospective study on multiple, at least I believe 6 or 7 academic centers to say, well, how well does mycophenolate mofetil work? I can tell you in my experience, very well. How do I differentiate for patients if they should do methotrexate or mycophenolate mofetil? Alcohol. Would stopping alcohol affect a patient's well-being, meaning their social life and such? If yes, then absolutely methotrexate's not the right option. We go mycophenolate mofetil. If somebody says, I'm fine not drinking alcohol, then we go methotrexate. What about IV methylprednisolone? So where this comes into play is when you need to shut this down quickly. Prednisone works quick. These other medications take about 2 to 3 months to kick in. So sometimes what I'll do is I'll pulse dose with IV methylprednisolone while the systemic medication orally is kicking in. So in conclusion, Morphea does not become systemic sclerosis. That's the great news, and that's why we refer to it as Morphea. If a patient does not have Raynaud syndrome, hand edema, or sclerodactyly, or proximal nail fold capillary abnormalities, they don't need further workup for a systemic sclerosis. In fact, in the past, there was a thought that it would progress to systemic sclerosis. When they looked back at those cases, it turns out that patients were actually misclassified. It was a patient with systemic sclerosis that should have been classified as systemic sclerosis from the get-go. Morphea is typically treated by dermatology, sometimes rheumatology. Find an expert. An expert will be able to tell you what the likelihood would be of treating. In fact, there's actually studies looking that general dermatologists have a tendency to undertreat generalized morphea and deep morphea, and linear morphea as well. Pediatric dermatologists treat a little bit more aggressively, but it is important to find an expert. Also, treatment is based on activity, depth, and patient preference. Morphea and systemic sclerosis are two of my favorite conditions to treat, absolutely. And if anybody has any questions, I'd be happy to answer them. Thank you so much.